multimedia and social media, people do not like very long speeches. So I also try to make the slides a bit interactive so that it won't be boring. So straight away, we would go into anemia prevention and control. Wow, my screen is frozen. All right, okay. So what is anemia? The World Health Organization defines anemia as a condition in which the number of red blood cells or the hemoglobin concentration within them is lower than normal. So basically, anemia is characterized by two main things, either very low levels of hemoglobin or very low levels of red blood cells. So it means that you can have enough red blood cells, but if the hemoglobin concentration in those red blood cells are low, you will suffer from anemia. Or you may have very low levels of the red blood cells itself. We know hemoglobin is the protein in the red blood cells that helps to carry oxygen from the lungs to all the tissues in the body. So since we are saying that the two main things that result in anemia is either the low levels of the red blood cells or the low levels of hemoglobin concentration in the red blood cells. Anything that results in these two things would cause anemia. So if you have excessive blood loss, you would likely experience anemia. Or if your red blood cells production is low, you would get anemia. Or if the destruction of the red blood cell is high, you would get anemia. What are the symptoms? The very common symptoms of anemia include fatigue, weakness, shortness of breath, pale skin, and this is characterized by the paleness of the palms, the under eyelids, and other portions of the skin. Then rapid heartbeat. These symptoms are all because if the blood is not able to circulate enough oxygen to the tissues, tissues will exhibit weakness. Your blood is not able to carry enough oxygen to other portions of the body, you would be experiencing shortness of breath. The hemoglobin is what also helps give the deep red color of the blood. So that is why you would have the pale skin. So these are all because of the low levels of hemoglobin and the low levels of red blood cells that you would exhibit these common symptoms. The treatment depends on the type of anemia and the underlying conditions that are involved. So we'll look at 6 main types of anemia. There are so many types of anemia, and the naming is usually descriptive. So you can tell the type by the name. The first one we'll be looking at is the iron deficiency anemia. So like the name suggests, it is as a result of the deficiency or the lack of iron in the body. It is the most common type of anemia, and iron is very essential for the production of hemoglobin. So if it is lacking, then you would suffer from iron deficiency anemia. Another type of anemia is vitamin deficiency anemia. So some vitamins are responsible for the production of red blood cells, key amongst them vitamins B12 and vitamin B9. The absence or the lack or the insufficiency of vitamin B12 and B9 can lead to vitamin deficiency anemia. And some examples of vitamin deficiency anemia, we have megaloblastic anemia and pernicious anemia. In megaloblastic anemia, because of the deficiency of the B12, the red blood cells that are produced by the bone marrow, they are abnormally large. And one may ask, if the red blood cells are large, so what? It doesn't mean that they contain higher levels of hemoglobin. In actual fact, the red blood cells are abnormally large, and the inner contents are usually underdeveloped. So what happens is that they tend to have a shorter lifespan. Normally, the red blood cells are supposed to have a lifespan of 120 days. But in megaloblastic anemia, they have a shorter lifespan. So they tend to die quicker than they are supposed to. And because their contents are also underdeveloped, it leads to anemia. Then another type of vitamin deficiency anemia is anemia. And it's a decrease in red blood cells that occurs when the intestines cannot properly absorb the vitamin B12. And the B12 is necessary for the production of the red blood cells. And the common causes are weakened stomach lining, which is basically an autoimmune condition in which the body attacks the actual intrinsic factor protein cells, those cells which are responsible for helping the body to absorb the B12. The body itself sees them as a foreign agent and attacks those cells. Or sometimes it attacks the lining of the stomach wall that make the intrinsic factor protein, and that inhibits the absorption of the B12. Then chronic infection with the bacteria Helicobacter pylori can also lead to these conditions. Then in some very rare cases, it can be a genetic trait that is passed down from one family to another, and it's called congenital pernicious anemia. And so children with this condition are not able to make enough of the intrinsic factor, and so they cannot properly absorb the B12 in their small intestines, thereby leading to the pernicious anemia. We also have aplastic anemia. It's also not very common. It's where the bone marrows are not able to produce enough of the red blood cells. They're not able to produce enough of the white blood cells and also enough of the platelets. Then we have hemolytic anemia. In hemolytic anemia, just like the name suggests, there's hemolysis of the cells. It means the red blood cells destroy or they dissolve faster than they are supposed to. It's also genetic, and it can also be as a result of infections, and some medications can also trigger hemolytic anemia. Then we have thalassemia. Thalassemia is also a genetic condition that affects the production of hemoglobin, leading to anemia. The last one we'll be discussing is the sickle cell anemia. It's also a very popular type of anemia. It's also genetic, and in sickle cell anemia, just like I said, names are usually descriptive. So in sickle cell anemia, the red blood cells are shaped like a sickle. So in the slides, you can see on the left how the normal red blood cells are shaped, and on the right, you see the sickle cell blood cells are shaped like a sickle. Now let's look at the prevention and control. So we'll look at the first one, which is the iron deficiency anemia. How do we prevent and control iron deficiency anemia? So since we said that iron deficiency anemia results from the lack of iron in the body, one way of preventing or controlling it is by eating iron-rich diets. So diets like liver, like fish, red meat, poultry, green leafy vegetables, or iron-fortified foods are all good sources of iron that can be used to control or prevent iron deficiency anemia. Another way of controlling or preventing iron deficiency anemia is by proper food combinations. So if you combine vitamin C-rich foods with the iron-rich foods, it makes the iron in the iron-rich food readily bioavailable. So you can have iron in your diet, but if that iron is not bioavailable, the absorption of that iron will be limited. So foods like oranges, pineapples, tomatoes, tangerine are very high in vitamin C, which when combined with iron-rich foods makes the bioavailability very high and thereby increasing their absorption. Then iron supplementation can also be used to control or prevent iron deficiency anemia. Then dealing with some underlying conditions such as gastrointestinal bleeding or heavy menstrual flow can also help to prevent iron deficiency anemia. Then regular screening, doing blood tests can help you to detect iron deficiency anemia early in order to ensure you have timely treatment and also prevent deficiency. Because in some cases, a person may be anemic, but may not exhibit the symptoms. And if you don't test in time, complications might set in. Then some foods contain iron inhibitors. So foods that are very high in phytates have iron inhibitors, and they can prevent the body from properly absorbing the iron in the diet. So especially for persons who are suffering from iron deficiency anemia, it will be good to avoid food items like coffee, tea, and other foods that are very high in phytates and iron inhibitors. Now let's look at the prevention and control of vitamin deficiency anemia. So since it's a vitamin deficiency, the easiest way is by eating a very balanced and a very varied diet. As we all say, and we all advise people, your plate must be colorful. So anytime you are eating, the person who wants to prevent and control vitamin deficiency anemia must eat food from different sources so that you'll be able to get the necessary nutrients and vitamins from all those sources. Then you can also prevent vitamin deficiency anemia by treating any underlying condition that is resulting in the vitamin deficiency. So for instance, there are conditions like Crohn's disease or celiac disease that result in vitamin deficiency anemia. Vitamin supplements like the B complex or folic acid supplements are also good ways of preventing or controlling vitamin deficiency anemia. Then regular screening. Regular screening is an omnibus way of preventing and controlling all forms of anemia because it helps to detect the anemia early so that you can treat it promptly and also avoid complications. Excessive alcohol consumption also results in poor absorption of nutrients. So avoiding excessive alcohol consumption would also help to control vitamin deficiency anemia. let's look at the control and prevention of aplastic anemia. So exposure to harmful substances like benzene and some pesticides can trigger aplastic anemia. So limiting exposure to these substances help in controlling and preventing iron deficiency anemia. Some medications that affect the bone marrow, like chemotherapy drugs, anticonvulsants, and antibiotics, are all to be avoided. So unless they are prescribed and the medical doctor is aware of your condition, these are medications that must be avoided because they tend to damage the bone marrow. Then treating infections. So there are some viral infections like hepatitis that tend to increase the risk of aplastic anemia. So treating them promptly will then reduce iron deficiency, aplastic anemia. And then treating underlying conditions. So some underlying conditions like Fanconi anemia or Fashman-Diamond syndrome. And if you treat these conditions, then it helps to prevent aplastic anemia. So as we said, the omnibus one is the regular blood screening, which helps for early detection, timely treatment, and the prevention of complications. Hemolytic anemia. So prevention and control of hemolytic anemia. If you treat the underlying conditions, the underlying conditions like autoimmune disorders or infections can lead to hemolytic anemia. If you treat those conditions, then it's a way of controlling hemolytic anemia. Then exposure to certain toxins like lead can also trigger hemolytic anemia. So if you avoid exposure to those toxins, helps to reduce or prevent hemolytic anemia. So I spoke about autoimmune disorders as being one of the underlying conditions. So autoimmune disorders like rheumatoid arthritis, like lupus, they all tend to trigger hemolytic anemia. So if you manage them, you'll be able to resolve hemolytic anemia. And since these autoimmune disorders result from overactive immune systems, the use of medications that suppress the immune system tend to also help control hemolytic anemia. Then in very severe cases, blood transfusions are given in order to control hemolytic anemia. And then treatment of infections. So infections like malaria can also trigger hemolytic infections, and other bacterial infections can trigger hemolytic anemia. Then thalassemia. Thalassemia, as I indicated earlier, is not so common and it's a genetic condition. So genetic counseling and testing is one way of preventing, so that if prospective parents are both carriers, they can advise themselves. Then prenatal testing is also one of the ways where the amniotic fluid is, a portion of it is taken and tested to determine whether the fetus has the condition, and that can guide decisions about the pregnancy, whether to terminate or not to terminate, how to manage its condition going forward. And regular blood transfusions are also used to help replace the abnormal hemoglobin with healthy ones, and also to prevent condition. And the thing is that the regular blood transfusion sometimes can lead to iron overload. And when that happens, they do ion chelation therapy. And in ion chelation therapy, it helps the body to excrete or remove excess iron from the body, because excess iron can also lead to complications. Then folic acid supplementations are also required to support the red blood cells in the production and also to prevent complications. Then bone marrow transplant is also done. It's quite expensive, but it's a curative treatment that is done for thalassemia patients. So once this is done and is done successfully, it cures the condition. Then we'll look at the last one, which is the sickle cell anemia prevention and control. So since it is also a genetic condition, genetic counseling and testing is one of the ways of preventing it, so that if both the man and the woman are carriers, then they either have to go their separate ways or they will be monitoring each pregnancy and determine the fate of each pregnancy and each child. So that's one of the ways. Then vaccinations because infections tend to trigger sickle cell crisis. So all sickle cell patients are advised not to miss out on any of their vaccinations. So they have to take their vaccinations on schedule so as to prevent the crisis. Then avoiding extreme temperatures, so extremely low temperatures or extremely high temperatures tend to trigger sickle cell crisis. So that is one of the ways. Then hydroxyurea therapy, it's a medication that is used in sickle cell patients to help control the condition. Then regular screening to help early detection and management is one of the ways to prevent and control sickle cell. Then adequate hydration. So those with the conditions need to hydrate well because as you can see, the ones that are sickle shaped, they look like they are distressed already. So if you don't hydrate and they have to get further wrinkled, then you are destroying them further. So hydration is very important for the control of sickle cell anemia. Then blood transfusions are also done to replace the sickle cells with the normal cells because the blood transfusion is the normal cells that are transfused into the person. So the omnibus control mechanism is the early screening, blood screening, and also education and counseling. So blood screening, education, and counseling apply to all types of anemia. And so this will help the people and the families to be able to manage their conditions and also prevent complications. So like I said, the presentation will be less than 30 minutes, and I hope I was able to speak within the time frame. Thank you. If you have any questions or comments, please feel free to ask.
Thank you very much, Fred, for this insightful and short presentation. So at this juncture, I would ask, the presenter said he was going to make this very interactive. So I will crave your indulgence to make it very interactive. So there are two things. If you would want to ask any questions, kindly lift up your hands and then I would call you. Or alternatively, you can also post your questions in the chat box and you'll be read. Yeah. So thank you very much, I must say, for the very insightful presentation. So now the floor is open for interactions, questions, comments, contributions. Yeah, all welcome. So any questions from the participants?
Hello.
Yes.
Yes, I want to commend Fred very much for that presentation. In fact, I was just recollecting the last time I had the opportunity to go into details, all the various anemias and how we can deal with them as and when we get them. Normally, because in the hospitals we see mostly the iron deficiency. If we don't take it, the day that we get a different one, it may be an issue. So for me, it's been a good CPD for me because it has reminded me of the others. And should I have any occasion to see any of them, I can properly help. Thank you.
Yeah, thank you very much for the comments, Anaemia. Any other questions, comments? Oh, the whole idea is to make it very interactive. So I would encourage us all to, make it very interactive. Any other comments? So,
okay, since the questions are not coming, let me ask the question. I'd want to ask the practitioners whether, apart from iron deficiency anemia, in their practice, they've been able to come across any other form of anemia.
yes, so this is to all of us, practitioners. Any experiences with managing the other anemias that Fred actually presented? Yes, Ghana Academy. So whose hand is up? I can't actually see the name.
Yeah,
well.
it's me.
Oh, it's you. Okay. Anaemia.
Yes. From experience, what usually happens is that if it is either, especially for the thalassemias, you realize that usually even the doctors wouldn't, they will treat it purely as a medical case. So when you even go to the ward round and you see a case like that, I've seen one or two, and usually it's like, yes, we have to help with the diets and help with the meal plan, but if the underlying medical case or cause is not dealt with, we may not have any. So that's the discussion between us and the doctors. So usually, yes, it's not so regular, but in my years of practice, I've seen a few which I can count, but usually you may not have, they were not even referred to the dietitian for help. It was our ward round that picked them up, but then it was like it's more of medical than nutritional. That's how it was. Yeah. Thank you.
Yeah, thank you very much, Anaemia. I think I saw Maxwell. Yes, Maxwell. RD Conlan.
All right. Yeah, thank you so much, Fred, for the presentation and the question. I think Anaemia has just mentioned about just try to come in. Yeah, I think just as he said, what I would like to add is that mostly the medical people sometimes will just refer the case as iron deficiency anemia. I feel that there most times they don't usually differentiate what type of anemia it is. for most cases. With the other forms, very few once a while, they will specify. So I think that it's for us to go back to our various hospitals and try to identify some of these different anemias and the best approach to address them, because I feel holistically, most of the anemia cases, when the full blood count comes in, they will just, diagnose it as iron deficiency anemia instead of looking at the other types. Yes, and one thing I want to add from these discussions of anemia control, taking a cue from the other presentations in the other zones, I think one thing is very clear that iron deficiency anemia is not the only anemia that we are confronted with. And so as dietitians, our take-home message should be that we should be looking out for the other forms of anemia, because the interventions would differ, especially when it's in a typical community where you are confronted with infections. The approach is going to be different. We are talking about dietary diversification. How do we do that? At the hospital, when the patient comes, we need to find a way in a local community of how we can solve this case. And in most of the things, we can see that iron deficiency anemia or iron anemia in general, including all the different forms, is very, very prevalent, and it's becoming more of a public health issue. And I think that if we have to fight to get this iron or whatever anemia issue out of the way, then we stakeholders as nutritionists and dietitians have a very much role to play in this situation. So I think that this is a very insightful discussion, and it should not end here. We should look at the other forms of anemia and see how we can be able to reduce the prevalence significantly. Thank you.
Yeah, thank you very much, R.D. Conlan. At least it is clear from our interactions and conversation that the key to managing this anemia also lie in how we're able to distinguish what type of anemia. Because if we are able to if you're unable to identify the specific type of anemia, the management or the treatment will be very difficult. So the key thing I'm getting from the discussion is us being able to correctly identify the type of anemia we are managing. So thank you very much, R.D. Conlan. I would also want to inform us that we have the registration form in the chat box. So you should kindly go in there and try and register, because it's very important towards the CPD points. Right? Any other question or comment or contribution?
So Dr.
Anaemia, yeah.
Yeah. I want to find out from Fred if there is any protocol at the facility level or the district level for managing the other forms of anemia, because I've seen a lot of Ghana Health Service led the nutrition unit. They do a lot of anemia workshops and all those ones, but I realized the emphasis, even though most of the anemias we have, majority of it is iron deficiency anemia, and now we are seeing these ones. Are there any protocols in managing the other forms, especially at the ministry and the Ghana Health Service level?
Okay, so what I know is that the protocols are developed at the facility level by the various heads. So usually the med soups at the various facilities will take lead in developing these protocols. So may not be available for all the types of anemia at all facilities. So if there's a facility that does not record, let's say, sickle cell anemia, they may not develop a protocol for treating sickle cell anemia. But if they are encountering sickle cell anemia consistently, then they will develop a protocol for it. Maybe one of the things we can be pushing is to see whether the various hospitals can identify some peculiar ones and develop protocols that can be shared across the board. In that case, too, it means we need data to know the prevalence of these types of anemia so that we will not be developing protocols for conditions that are not prevalent in the various communities where this hospitals are. Thank you.
Yeah, thank you very much, Fred. Any other question?
So I have a follow-up to that. Fred, we have quite a number of iron sickle cell anemia cases. But for our facility, we have sickle cell clinic and all that. There are a lot of research, pieces of research that have been conducted in this area. And we are supposed to be helping them with their care. You usually realize that when the sickle cell cases or they have crisis and they are at the hospital, sometimes they are eating and all those one becomes even a challenge because they don't even feel like eating. We have quite a number of transfusions and all those ones there. Do you share in my frustration? If you've been managing them, do you share in my frustration as in sometimes you feel handicapped in helping them?
I understand your frustration. The thing is, if you are encountering a lot of the sickle cell anemia cases in your facilities, then you need to draw the attention of the medical suit to make sure that a protocol is developed. Because, for instance, we never had protocols for managing COVID. But when COVID hit us and we saw that it was a public health crisis, the facilities were mandated to develop protocols for managing COVID. Isolation wards had to be quickly put in place and things were put in place. Even facilities that do not even have enough spaces had to make space available to isolate patients because isolation was part of the protocol. So I think you need to engage your medical soups so that the protocols will be put in place. It makes the work easy because it presents a template that you can follow on and then be able to manage your case.
Thank you very much. Any other question? Any other question, contributions, or comments? I think we still have some time, about nine minutes. So I would encourage that if we have any questions, yeah.
Okay, since the participants are not asking, let me ask another question. From practice, are you able to tell from interaction with the patients whether they are able to see the correlation between their diet and anemia?
Yes, so to the participant, I would want you to hold your thoughts on this question. So there's a question in the chat from RD Agodo. Interesting conversation. What would you say is the present differences in the scope of practice between nutritionists and dietitians in anemia management? So Fred, this is a question from one of our participants.
This issue about nutritionists and dietitians, it's for me personally, where I stand, I feel it's an unnecessary politics. Because both groups need to just have a compromise and work together. There are cases where some nutritionists see themselves to have a public health scope, and the dietitians see themselves to have a clinical scope. I think it should just boil down to practice, because we have nutritionists that are doing clinical work. I know a number of them. And we even have dietitians who are also doing public health work. I also know a number of them. So I think the distinction should not necessarily be with the title you carry, whether you're a nutritionist or a dietitian, but it should be in your scope of work. And that should solve. I don't know if I've satisfactorily answered the question.
So maybe I probably would try to clarify. I think the participant is actually asking if you see any differences in the scope of practice, specifically in the management of anemia, between these two professions. So I don't know if you have covered that part in terms of your response.
I don't really see much of a difference, just that the orientations of the individuals would be what will bring the difference, because from the get-go, most dietitians restrict themselves to clinical work, and most nutritionists restrict themselves to public health work. But if you get to the field and you realize that what you are faced with is clinical work, regardless of whether your orientation is public health oriented or not, you would have to pay attention to the individual in front of you and deal with the clinical conditions of that individual. If you are dealing with a larger population, regardless of whether your orientation is clinical work, you have to look at the trend in the population and bring your public health skills to play. So I personally do not think that there should be a difference in their scope of work, and that is where I stand. But it's been a debate that has been raging on, not today. So I'm not sure my answer will settle these debates now.
Okay, thank you very much, Fred. RD Porty, I saw your hands up. Do you have any questions or contributions?
Yes, thank you, Dr. Hayford. I just wanted to inform everyone about the attendance sheet. The link is in the chat box. So let's do well to fill it so that we can capture your attendance. And then after you make payment, or for those of us who have made payment, your names can be submitted to the Allied Health Professions Council so that your points will be credited to you. But notwithstanding, all of us should do well to fill the attendance sheet. Probably if not paid now, you pay later. So just do well to fill the attendance sheet. Thank you very much.
Yeah, thank you very much. Yeah, for the reminder. So so someone is saying that they cannot see the attendance sheet. So if you can post it again, for those who probably join later to complete the attendance sheet. I think we still have about 4 minutes. So if we have any questions or suggestions or comments, we can do that now.
I asked the question about whether the patients have been able to show any correlation between, they've been able to show any knowledge of a correlation between their diet and anemia.
Yeah, so this is to all of us, right? Any response Any experiences? So do we have any experiences in connection with the question that Fred asked? Looks like our audience today are extremely quiet. I don't know if it's because of the topic. You've enjoyed it so much that you don't have anything. Everything has been touched.
I think the weekend bell is belling. The weekend bell is pressing hard.
Anyway, one of RD Agodo is actually asking if it's the question.
So I think that hello, Frank.
Yes.
So if I understood him, he's asking whether, as we interact with our patient, they are able to correlate link the dietary intervention and anemia control. I don't know whether that's the question he's asking.
Yes, please. That's exactly the question.
Yeah, so usually you have a few people during the dietary history intake who are well read, but who have read a lot before coming. So they can say that, oh, I hear if you take this, and they may tell you some of the things that we take. Please hold on. Oh, good. All right, some of the things that they have read they should take, maybe they don't like or they like. Others too will say things that we don't even have some data to support, like taking tin tomatoes and Coca-Cola, some taking malt and milk, and all those ones. Like if you do that, your blood level will increase. So there are several things like that that we hear, but a few, not more or not many, really have read and before they come. And the others, they will always sit and say, "Oh, you tell me what to do, and I will do." So that's my experience.
Thank you very much, for sharing your experience. Any other question? Yes. So then I think on this note, I would like to say a big thank you to our presenter, Fred, for this insightful presentation. I mean, I also consider the presentation as a very good reminder when it comes to anemia, prevention and control. I would also like to thank all our participants for making it today. I don't know if any of the Southern Zone executives are here and they would want to give any announcement. I would want to remind us that this is actually a Southern Zone meeting. This is the very first in the series of meetings that we'll be having in the course of the year. So I don't know if any of the executives are here and would want to give any announcement or information. This would be a very good time.
Yeah. Okay.
Yes, yeah, go ahead.
Yes, please. So thank you all very much for joining this very first Southern Zone maiden CP. It's been a pleasure having you, and thank you, Dr. Hayford. Thank you, our presenter, Mr. Fred. To the rest of us, I think this is a good start. So, at Southern Zone, we plan to have a series of CPD that we intend to do. I think our next CPD will be somewhere next week. We are working hard to make it in person. It's been a long while. I think after the conference last year, it's not really had an in-person CPD. So we are working at it so that we can meet in person and see our beautiful faces. I think because of data and bandwidth, people just put off their video when we are doing this virtual conferences. So we hope to see you next week on the 3rd, on the 4th of May. We have a CPD coming, and details of it will come shortly. And then I hope to see you, all of you there. And very soon we'll come to you all and then have a general meeting, a Southern Zone general meeting to together reason and know the way we should help GAND as the Southern Zone. Thank you all very much for being here this afternoon.
So thank you very much, Aldi Corte. So on that note, have a lovely weekend, and until we meet again, goodbye for now.
Bye-bye. Great moderation, Dr. Hayford.
Bye.
Thank you very much.